I wanted to just start by saying how genuinely thrilled I am to be here, in a way for two reasons. First of all, because of the decisions that each and every one of you have made to do this, because you are embarking on something that's immensely valuable and will have a real impact on people. And you should feel very proud of yourselves for having chosen to do it and for having been selected to do it. It's also in a way a relief, because having, as Ella said, proposed the whole thing, it does rely on people actually applying to do it for it to be in any way a success. So thank you for that. But I'm also thrilled because it's given me an opportunity to escape from what I call this country's leading dysfunctional institution, the Houses of Parliament, which is just a total nightmare at the moment. I can't wait till the summer recess, but just escaping for the afternoon means a lot. So thank you very much for inviting me. I wanted to, first of all, the broad theme is about the campaign for equality, equal treatment for people with mental ill health. But I wanted to first of all set the context for what I want to say. First of all, on a very personal level, our family has been touched by mental ill health, as I guess probably most of yours have been. Our oldest son, first of all, diagnosed at the age of 16 with obsessive compulsive disorder. And for those of you who know about that condition in its true form, not in the sort of rather trivialized form that people often talk about, you know, when people say feeling a bit OCD today, but in its true form, it's a punishing condition. And if you imagine being a teenager trying to cope with all of the strains of growing up, but also having to cope with really dark, punishing thoughts that you can't escape from. And I remember the moment when Archie, our son, who incidentally has given me license to talk about his experience, but I remember him saying to me, "Dad, why am I the only person who's going mad?" And you know, to hear a 17-year-old speak in that way, and the sort of sense of loneliness that experiencing all of that on your own and thinking you are the only person who's going through it must be incredibly difficult. And he's thriving now at the age of 31, but we went through years of emotional turmoil in trying to cope with that. We were let down by the NHS. We were told we'd have to wait 6 months for any sort of treatment. And of course, here's the great injustice, because as a family, faced with that sort of crisis as we saw it at the time, what did we do? Well, we paid for treatment for him, as I guess any family would if you're able to. But of course, most families can't afford to do that. They are just left waiting. And we can't tolerate that injustice. And these things that happen to all of us in our lives help to shape how we think about things. We were also told, incidentally, that, I visited the Maudsley Hospital, where they have a fantastic anxiety unit there, and I met with a guy called Paul Sarkowski, who's one of the country's leading experts in obsessive compulsive disorder, and I wanted to understand more about the condition and how we were supposed to respond to it. And he said to me, "We can certainly help your son. Ask Norfolk to refer him to us. We can probably see him within 3 or 4 weeks." So I went back to Norfolk, which is our home county, and said, "We'd like you to refer Archie to the Maudsley, please." And they said, "We can't. He has to be treated in Norfolk." And I said, "But what about the legal right of choice introduced by the then Labour government into the NHS? Mental health is excluded from that legal right of choice," I was told. And so that was one of the things that I ended up correcting when I became minister, because it seems to me to be wholly without justification that people with physical health problems can choose where they get treated, but someone with a mental health problem gets told where to go, and you take what you're given and nothing else. It's still not working properly, incidentally, but the legal right has now been rectified so that it's equal across physical and mental health. So that was our experience with our son, and it was at times incredibly difficult and traumatic. And then in 2015, my older sister Catherine, after a period of acute clinical depression following the death of our mother, took her own life in 2015. And I'll return to that a little later. Again, our experience as a family is no different to very many families across our country, but it means that in a sense I have some insight into very many of the horror stories that came to me as minister, but come to me now as a constituency MP and someone who sort of actively campaigns for improved treatment, equality of access and treatment for people with mental ill health. So that's the sort of personal. Then I want to mention the global context here, because I think it's also important. I think we're on a journey with mental health. You go back 1 or 2 decades, and across the world, people with mental ill health were discriminated against in all sorts of ways, everywhere, including in this country, within the law. And just one little example of that. It's only just a few years ago, it was the coalition government that finally brought it to an end, but one example is that if you were a member of Parliament and you were sectioned for a period of time, you were automatically disqualified from being a member of Parliament. That's just one example. That's now ended, but all sorts of ways in which people with mental ill health are discriminated against. But the disturbing thing is that across the world today, that discrimination remains in place in very many countries, and not just in the developing world. So in many countries, if you have diagnosable mental ill health, and obviously there are different thresholds from place to place, but in many countries, there are rules against marriage, for example, against owning property, against entering a contract. So if you think about it, this is a human rights issue. You can't begin to justify unequal treatment of people because of experiencing mental ill health. But that persists today in very many parts of the world. And if you think about it, if it's entrenched in the law of a country, it's hardly any surprise that the general treatment that people receive in those countries, people with mental ill health, is going to be discriminatory. If it's embedded in the law of the country, for goodness sake, then you are going to suffer disadvantage in your lives, particularly in those countries. But we should not be complacent in thinking that the issue has been resolved in our country. The laws are now, on the whole, equal in terms of the treatment of people with mental ill health and others. But in all sorts of ways, particularly in our health and care system, people with mental ill health are discriminated against, bluntly. They're treated as second-class citizens. Also within the benefit system, we know that. We know the way in which the system works. And it may be in part because it's often more difficult to assess the level of someone's disability when it's not visible to the eye. But nonetheless, the impact is that people with mental ill health are discriminated against within the benefit system in this country. But within the health and care system, there are all sorts of ways in which people with mental ill health get discriminated against. So, for example, within our inpatient care of people with mental ill health, the use of force, restraint, is endemic in our system. Now, in 2014, I introduced guidance. It was after Mind, the organisation Mind, had done a Freedom of Information Act survey of the whole country to look at the use of force, the use of restraint, seclusion, forced medication and so forth. And their findings were pretty shocking, and it made headline news. And at the time, no data was collected. So I had no idea as minister until a campaign group did a Freedom of Information request about the scale of the problem. And in particular, they found that the use of face-down restraint, where someone is grabbed and held to the ground with their face to the ground, was endemic across our system. So that triggered, because I launched it, a review of the guidance on the use of restraint, and it led to new guidance being issued in 2014, which was designed to end the use of face-down restraint. Why? Because the advice I got from many progressive practitioners was that we can avoid, in almost all circumstances, the use of restraint at all, and we can certainly avoid the use of face-down restraint. So here's the question. If we know through evidence of practice how we can avoid it, to use it is surely unacceptable. And it's surely a breach of someone's human rights for the state to use force against them if we know how to avoid it through good training, through setting the right culture, and so forth. Tim Kendall, the National Clinical Director for Mental Health, in his unit in his trust in Sheffield, ended the use of face-down restraint at that time and was demonstrating how you could avoid its use. Merseycare in Liverpool, brilliant organisation, who I think now are participating with Think Ahead. They led from the front, ending the use of face-down restraint and experimenting on how you could avoid using restraint at all in inpatient settings. And what they found was that not only did it dramatically improve the culture, I remember going along there on a visit, the Liverpool Philharmonic Orchestra, the cello player from the Liverpool Philharmonic was playing cello to a group of blokes on the inpatient ward. It was an extraordinary and slightly bizarre experience, but it was wonderful at the same time. And they also discovered that staff were not getting injured as much at work, despite staff being worried about not being able to use restraint because they felt they would have to. By getting the culture right within the organisation, by applying positive behaviour support, they were able to avoid its use and they got injured at work less, and so saved on sickness absence, and everybody benefited as a result. So that was just one way in which, in my view, people with mental ill health receiving treatment within the NHS get treated in an inferior way. If we can avoid it, we have to avoid it, and yet we fail to do so. Scroll forward, incidentally, to today, and we haven't eradicated, despite the guidance, the use of face-down restraint. It's still being used in very many institutions, and the use of restraint generally is still heavily used. And if anything, is going up, because often stressed environments where they're using agency staff, people not without the necessary training are using sort of crisis management to contain situations. But just imagine this, if you are perhaps a woman who has suffered abuse in your life and you end up in inpatient care and you're restrained with 6 or 7 people holding you to the ground, this re-traumatizes people in an often frightening way and completely destroys the trust between staff and the individual. We have to do better as a human rights issue within our mental health system. Another example, it is just routine practice still that people brought into inpatient care in an emergency are then shunted around the country in search of a bed. This would never happen in physical health, but it happens routinely week after week across our mental health system. And yet we know there are some mental health trusts that have organised themselves in such a way, without vast amounts of extra funding, through better preventive work in the community, to stop admissions in the first place, to looking at the length of inpatient stay, and so freeing up beds by stopping the unnecessary long inpatient stays that happen in many, many places around the country. Many trusts have been able to demonstrate how you can end out-of-area placements. So what are we doing, allowing other trusts to do it routinely, week after week? And I had a constituent a while ago, a local journalist, who in the middle of a crisis was sectioned. There was no bed available in Norfolk. He was placed into a van late in the evening and driven off with him having no idea where he was going, with a man next to him who didn't talk to him for the whole journey, ending up in a private hospital in South London where he was contained for about 10 days, no therapeutic input, before returning to Norfolk. Unacceptable. And it would not happen in physical health care. So this is an abuse of someone's rights to be shunted off somewhere else around the country. And then finally on that, the mere fact that we lock people up in inpatient care, many people who don't need to be locked up, for me is unacceptable in this day and age. The Care Quality Commission 2 years ago did a report on what are wonderfully described as locked rehabilitation wards. Now, I find that a total contradiction in terms, to have a locked ward for rehabilitation, but this is what they are called. And yet the Care Quality Commission concluded, as a result of their survey, that there are very many people in the 3,500 beds in these locked rehabilitation wards, many of them in the private sector, but not exclusively, who don't need to be there. Now, just think about this. If there are people locked up, not because they've committed a crime, who don't need to be locked up for their medical needs, but are still locked up because nothing's been sorted out for them in the community, not acceptable. A breach of their human rights, locking someone up, for goodness sake. So this is what drives me to keep fighting for equal treatment. And I regard it as a human rights issue that we have to keep fighting. Now, I want to just say a word about my time as a minister. I was there from, as Ella says, from 2012 to 2015. There were a number of particular things that we drove forward in that time. I felt on a mission. Look, I'm a Liberal Democrat. I never imagined I would be a minister. So I found myself rather unexpectedly in the Department of Health, actually doing something that I wanted to do, that I cared a lot about. So I felt on a mission, and I knew for certain, because I just looked at the opinion polls, that we would be out in 15, that we would be almost destroyed, and, as we duly were. Thankfully, I was a survivor of that experience in 2015. But I knew that I had a limited time period to try to achieve things. And I wanted in my time to just drive the agenda of mental health and to always ask the question internally, whenever the Secretary of State, with all the great and the good of the NHS around the table, were poring over acute hospital performance every Monday morning, looking at their performance against the 4-hour A&E target, the performance against the cancer waiting time standards, the performance against the 18-week referral to treatment target. And my responsibility was to always say, yeah, but what about mental health? Because it was being completely ignored. And if you think about those maximum waiting time standards introduced in the last decade, where are the ones for mental health? They were completely absent. There was nothing. And this drives where the money goes within the NHS. And I could see it at the heart of the department. All the great and the good, as I say, every week looking at the performance of individual hospitals and demanding improved performance against those standards. And so every clinical commissioning group around the country, panicking that they have to meet those standards, shifts a little bit of money away from mental health and into acute care. That's what happens. And so I was determined to embark on a journey which would equalise access, the right of access to treatment between physical and mental health. And we introduced the first ever maximum waiting time standards, the 2-week standard for early intervention in psychosis, because we know that starting quickly gives people the best chance of recovery, and the 6-week standards for access to the IAPT psychological therapies program. So we did that. We introduced something called liaison and diversion to divert people when someone arrives in a court or a police station with clear mental health issues, to divert them to diagnosis and to treatment. I think the rollout across the country is now complete. It's not working perfectly, but at least it establishes the principle that if you go into the criminal justice system and you have mental health problems, you should be helped, not simply punished. And I believe that it is a scandal of our time that there are so many people with mental ill health, with learning disability, with autism, and with the diagnosis of personality disorder in our prisons. It's a disgrace that we lock these people up where often it's the condition, the mental health condition that they suffer from, which drives the offending behaviour, not the right way to treat people, a breach, again, of their human rights. And then, along with a host of other things, including setting standards for crisis care, a blueprint for the modernisation of children's mental health services, which was called Future in Mind, which was published in 2015. The final one that I wanted to just highlight is the establishment of Think Ahead. And the story, very briefly, was that I read the Times one morning, and there was an article by Andrew Adonis, who was the person behind establishing Teach First. And the article in the Times was describing how they had applied the principle of Teach First to introduce a new scheme for children's social work. And it was a very positive article, and I was impressed by what they were doing. But I was left thinking, but what about adult social work? It's left out of the picture completely. So at that stage, that was the question that I asked. And we brought together people. I met with Andrew Adonis, with Alistair Campbell, for example, and we started thinking about what we could do. And we commissioned IPPR, the think tank, to look at what we could introduce. And they recommended, which was in large part because it was totally consistent with the overall theme of trying to enhance the experience of people with mental ill health, that we should address the Cinderella service within adult social services, social work, which was that area that focuses on mental health social work. And we should introduce a fast-track scheme to address that paucity of attention and care that had been given to this part of the social work system. And so we then secured the money, we set up the organisation, and it is what it is today. And for a while I served on the board of Think Ahead. It was a privilege to do so. But for me, this is an immensely valuable development. And I suppose the last thing I wanted to say relates to Think Ahead, because back at the end of 2017, I turned up as a board member to a reception put on to publicise the work of Think Ahead. And we had a drinks reception, and then we all went into an auditorium, and some of the graduates on the programme talked about their experience. And there was a lad called Jack who talked about how his work on the programme had particularly focused on rebuilding people's social connections in the community, helping them to recover their sense of self-worth. And I was very moved by what he said, and I thought to myself, my sister, who had been an inpatient for 10 weeks in a really dismal unit, which in my view was simply not a therapeutic environment to recover. And yet it would have cost a fortune to the system to keep her as an inpatient, containing her, along with a lot of other troubled people, for 10 weeks. And I just thought to myself, that money could have been spent so much more creatively on people like Jack, helping her to rebuild her life, to rebuild her connections with neighbours, with friends, with other social arrangements that she had been involved with previously. And it might, who knows, it might have possibly given her a reason to live. But I just thought Jack and all of you are doing such valuable work. And it set me off on a train of thought about how we still need to shift the culture in mental health. I talked about, all of those breaches of people's human rights that continue to exist within our mental health system. So I brought together a group of reformers in mental health, some GPs, some psychiatrists, psychologists, some people with experience of mental ill health. Big failure. I didn't actually include mental health social workers, so apologies for that. I will do so next time. But we came up with a vision which we call Care Not Containment. And our thought is that along with campaigning for more money for mental health, which I will always do, it's built into my DNA that I will fight for a better deal for mental health. But I'm left also with the sense, and the document that we produced articulated this case, that we could spend the money that we have got already so much more effectively by ending inappropriate long stays in institutions where we often institutionalise people. Just think about this contrast. In the UK, I know this is relating to children and young people, but in the UK, the average length of stay for a teenager in a mental health unit, if they're admitted to one, often incidentally a long way away from home, is 72 days. The average length of stay in Australia is 10 days. Now, it's not to say that everything in Australia is great, because it's not, but it's a very different approach. And I have a fundamental view that very often we contain people in those lot rehabilitation wards, we contain people in mental health wards, in mental health trusts and in private units around the country with no real ambition for their recovery, for enabling them to live a better life, to enjoy life as we all take for granted. And that's my continuing mission, to fight for a shift of culture, to shift resources away from containment to early intervention, to supporting people in the community, where possible to prevent mental ill health in the first place. But if that's not possible, to prevent a deterioration. And that is where you are so valuable, because your role can literally change people's lives. And I end where I started by thanking you all very much indeed for choosing this very worthy calling. Thank you very much indeed. Well, I've just been talking to over 100 participants in the Think Ahead programme here at Middlesex University, and it's been brilliant to meet some really inspirational people. And one of the messages I wanted to get across to them was my personal gratitude to them for each individually having chosen this course of work for their future, because they are going to be involved in the most important work. And my passion is about how we change the culture in mental health, how we fight to ensure that every person gets treated as an equal citizen, that we end the sense that people with mental ill health, particularly in our health and care system, get treated as second-class citizens. And people who've gone through the Think Ahead programme will be passionate advocates of a human rights-based approach, treating people with dignity, with respect, changing that culture in our mental health services. So it was wonderful to meet them all today, and I'm so excited about how successful this programme is, and it has the potential to have a massive impact on people's lives.